So on behalf of AO Trauma North America, I'd like to welcome you to our webinar. My name's Tom Hunt, and the subject of our webinar tonight is thumb carpal metacarpal joint arthritis. I'm very fortunate to have four superb faculty here that will discuss all aspects related to basilar thumb arthritis. First, Dr. John Elfar, the endowed Baker Professor and Vice Chair of Orthopedics at Penn State in Hershey, Pennsylvania. Dr. Kevin Malone, Associate Professor and Chief of Hand and Upper Extremity Surgery at Case Western Reserve University School of Medicine in Cleveland. Dr. Glenn Gaston, Fellowship Director at Ortho Carolina and Chief of Hand Surgery in Charlotte, North Carolina. And finally, last but not least, Virginia O'Brien, the Hand Therapy Residency Coordinator at the University of Minnesota Health and Hand Center in Minneapolis, Minnesota. So these are our disclosures, and you can see fairly minimal disclosures from most people, just listed there. Just an overview. So basilar joint arthritis is, as we know, an exceedingly common disorder diagnosed and treated by a variety of different types of hand specialists, including surgeons and therapists. This webinar will focus both on the non-operative and operative interventions, including some less invasive options, as well as those utilizing new technologies and new strategies designed to maximize outcome. The faculty will emphasize these evidence-based options, but through their experienced eyes. So the learner objectives, I won't go through this in detail. It's listed on pre-webinar publications. So our agenda first is a welcome by me, and then we'll learn about pathophysiology and early treatment options from Dr. Elfar, followed by comments from Ms. O'Brien. And next is surgical options and techniques from Dr. Malone and O'Brien. And finally, complications of surgical treatment with considerations regarding revision surgery from Dr. Gaston and O'Brien. And then finally, if we have time, some questions and take-home points. So I would like to remind you all too, if you would please bring your questions forth through the Q&A tab. We're not using the chat tab as part of the questions. So with that, I'll stop sharing and ask Dr. Elfar if he'd like to take over.
I'm here. Just give me 1 second. I will share. So you should see a title slide, everyone. I hope you do. Somebody say if they don't.
Yes.
Okay. Okay, so good evening. Thank you for listening to us and spending part of a precious evening with us. I'm supposed to kick this off a little bit with an introduction to our favorite. This is like one of the favorite topics of all hand surgeons, is basal joint arthritis, or TMC arthritis. Sorry, 1 second. So the learning objectives just from this area, this little mini talk, are to present you with one model of pathophysiology of basal joint arthritis. It turns out that there's more than one of these models, and there's some contention about it. The basics of staging, some non-operative splinting, and then some concepts of early intervention as best we can. So first, we want to talk really about the reason why people have basal joint arthritis. And it's important to know that basal joint arthritis is a very common it's a very common site of arthritis. This is the trapezium. You can see my mouse, and this is the metacarpal. And it was shown many years ago that arthritis in this joint starts at the volar beak area here. And then it progresses across the joint These are early studies. These were provided by Dr. Pellegrini, early studies showing early eburnation in one area, but less involvement in the areas more dorsal. And this is a picture from a paper many years ago. Dr. Pellegrini's theory sort of focused on the attritional changes in the palmar beak ligament, and detachment of that ligament led to instability and the kicking out of the metacarpal over time. That's how these wear out. This leads us to staging. And I think that actually one of the weakest areas of basal joint science or carpometacarpal joint arthritis science is the staging. The staging is actually from decades ago. And it used to focus on the size of osteophytes. I've removed that because I don't believe that many people believe that the size of osteophytes or ossicles is the critical factor. These are things that I think most people agree on, that at stage 1, you have normal contours, and at stage 2, you have slight narrowing. And then at stage 3, you have a narrowed CMC joint. And then at stage 4, you start to get involvement at this STT joint. It's really easy to find in your own practice patients who have horrible arthritis elsewhere in the wrist that may be associated with this. But this is sort of the general gist that most people agree on. I wrote here meh. This originally had the size of the osteophytes, as I told you. And few people can agree reliably. There's papers on how people can't agree on the difference between stage 2 and stage 3. And so some people favor a stage 2-3. And there was originally a lot of focus on subluxation as a factor, but there's also it's hard to agree. I prefer mild, moderate, and severe, where moderate is probably the stage 2-3 involvement. There's a general treatment scheme here, and I think most people agree that treatment depends on the stage of the disease as well as the degree of the patient's discomfort. And I want to emphasize that if you've been doing this for a long time, you know that the degree of discomfort really doesn't correlate so well with the stage of disease in some patients. There's conservative treatment. We're going to talk very briefly about rest, NSAIDs, steroid injections, and then there's this splint that has been used for many years, which maintains abduction, and when it's custom made, it can be a hand-based splint. And then there's surgical treatment options, and I'm only going to talk about a few surgical treatment options that we tend to use in early stage disease when nothing else is working and it's crippling a patient. Okay, so conservative treatment centers around this kind of thing, this kind of splint. I don't want to say that everybody needs an orthoplast, custom-made, hand-based thumb spica splint. It's what a lot of us were trained to use. Some of us use off-the-shelf splints. Swigert et al., Journal of Hand Surgery in 1999, evaluated 130 thumbs treated with 6 weeks of splinting. In the early stage disease, stage 1 and 2, they had 76% improvement, but only 54% improvement with the later stage disease. Overall, I think most people, most people would say that splinting is well tolerated, and it's an effective protocol to diminish, but probably not eliminate the symptoms of basal joint arthritis. I will say that one clinical pearl is when patients get a splint, I usually make them wear it straight without taking it off except to wash their hands for 2 weeks, because it's hard to know whether the splint is helping if you take it off every few minutes to do something. And it's actually hard to function with your thumb immobilized for a lot of people. The operative menu, there are many operations for basal joint arthritis and they all work. So how do you pick the operative menu? Well, there's arthroscopy, there's metacarpal osteotomies, there's ligament reconstruction, and only those 3 in red are the ones that are in my little section. But there's also resection arthroplasty or trapeziectomy, with and without the pin. And there's prosthetic arthroplasty, something that has waxed and waned in favorability over the course of the years. And then there's ligament reconstruction and tendon interposition. And then there's thumb Cmc Arthrodesis, which is a really viable option in certain patients. So what is the metacarpal osteotomy? This has been around for a long time. This is my favorite early stage manual management method. And the reason why is because it works. I've done this several times in patients where I didn't think anything was going to work. The base of the thumb metacarpal is realigned. Look here at this this closing wedge. This wedge is removed and the base of the metacarpal is realigned. It's important to know that although it seems like you're moving this part of the metacarpal out, in reality, it moves this part of the metacarpal in, this proximal side. And that's what actually shifts the weights or the pressures inside the joint. It's done for Eaton stage 2. There's 12-year follow-up on this from this very old paper on 23 osteotomies. It was a 30-degree osteotomy. I still make 30-degree osteotomies when I do this. And the indications is the high demand hand with the young laborer, but early stage. And I've done this more in non-young laborers than I have in laborers. Next is the volar ligament reconstruction. This is my sort of second thing to think about. I like the osteotomy a little better. It's done using the radial one half of the flexor carpi radialis distally, a hole is placed in the proximal metacarpal, and essentially this ligament is strung around it to reconstruct the volar beak ligament. And it's placed deep to the abductor pollicis longus, and it's deep to the intact flexor carpi radialis, and its final anchor point is that abductor pollicis longus. So Eaton et al. Investigated this a long time ago, early stage, 50 reconstructions, and they had 95% good to excellent results. The long-term results were looked at again by the same group 15 years out, and they had 90% satisfaction in their group. So this is a really good option. I haven't favored it as much because I think tensioning is somewhat dicey here. Most people who do this actually put a pin in to hold the tension right while they're stringing this ligament, this neo ligament into position. I do want to talk about arthroscopy, and I actually purposefully got these pictures. I'm going to take you through them one at a time. From a colleague of mine, he's a sports surgeon. He has a very large series of these. He works in rural Pennsylvania. His name is John Furia. And I like them because they're simple. This picture emphasizes just how simple this approach is. He just did this on some cadavers, and then he started to do this pretty routinely. Arthroscopy is usually done with X-ray guidance to make sure that you get into the joint. This is the setup. This is the X-ray image with a needle in the joint, and you can tell there's not much traction applied here. This is one of the joints like the shoulder. If you apply too much traction, it gets tight. I'm sorry. It gets tighter and harder to maneuver inside the joint. Look up here. This is what it looks like with some weight over the table. When I do these in a tower like wrist arthroscopy. But you can see this can be done very simply. This is introduction of the camera, and this is I'm sorry. This is preparation of the portal site and introduction of the camera. This is the instrumentation portal. This is generally the safer area. This is the area where people worry about the radial sensory nerve and the radial artery branches up here. There's actually a paucity of literature on arthroscopy the way I use it. I use arthroscopy for early stage disease, and I use it very rarely. But there's a lot of literature on arthroscopy as part of a ligament reconstruction and tendon interposition. I take these following slides from Dr. Yao. Jeff Yao has written probably as much as anyone else has on this. This is his review of the literature. And you can see that way back in 1996, there were publications on complete relief. But again, this procedure is different than just arthroscopy. And arthroscopy and debridement is what I've used arthroscopy for, not as part of a ligament reconstruction and tendon interposition. Typically, when people do this for arthritis in late stage, they do a hemitrapeziectomy. Most people who do the hemitrapeziectomy say the full trapeziectomy is somewhat technically challenging, although I've done that once. And then there's an interposition. The interposition can be done with any number of things. Here you can see in this paper, Palmaris longus Fcr, and back then Gore-Tex was still an option. Berger did a study in 1997. Dr. Culp in Philadelphia found that there was less subsidence of the metacarpal and comparable pinch strengths with classical papers. And then it's been done with other things like a graft jacket or Artelon. It's also been done in the military. This is 18 out of 18 satisfied at 7.5 years afterwards, despite a little bit of subsidence. And I think most of us agree that a little bit of subsidence is probably okay. The results of this is one paper that's particularly prescient. It's a paper that was written by Dr. Yao and his colleagues. And 23 patients, mean 14-month follow-up. They had very little pain just after a few days, which I don't think can be said with my standard basal joint arthroplasty. They had a full range of motion within 3 months. And this became a go-to surgery for the surgeons who do it as a way to get patients back faster with a return to full activity at 6 months. Although I have to say that with standard basal joint arthroplasty, very old literature shows that there's probably return to full activity, sometimes similar. I do want to highlight these two papers. This is another paper up here by Dr. Yao. It was in the Journal of Arthroscopy. This was suspending the metacarpal now with a suture button. There's a fair amount now written about different ways to suspend the metacarpal and prevent it from subsiding. I like this paper as well. This is by Dr. Slutsky. And I want to read just this one sentence here. Cadaver training is desirable, 2 sentences, I apologize. Cadaver training is desirable before embarking on a clinical case, and questions regarding the use of a temporary K-wire fixation or thermal shrinkage or the need for a natural or synthetic interposition substance cannot be answered at this time. This paper was from a few years ago. I do want to highlight that all of the papers I've cited so far, almost all of them use some amount of capsular thermal shrinkage. And for those of us who do shoulder surgery, we've seen some negatives about that in the literature. The gurus of arthroscopy as part of a ligament reconstruction and tendon interposition surgery do use it, although Dr. Furia, my friend in central Pennsylvania, does not. So it's an issue, something you have to think about. That's really it. I didn't want to take up too much of your time. The take-home message here is that basal joint arthritis is common, and it follows a reliable pathophysiological, pathoanatomic course with arthritis starting at the volar beak ligament and then moving more dorsally. A staging is a factor in deciding what to do. Some years ago, I asked Richard Burton himself, what about a better staging for basal joint arthritis? I think we have really good surgeries. We don't have a staging system right now that dictates definitively what surgery has to happen for what stage. And early stage interventions do exist, both open and arthroscopic. I just want to emphasize that arthroscopic debridement is a thing, even though debridement alone is a thing, even though very few people write about it. And I want to thank you for your time.
That's great. Thank you very much, John. I think your comments regarding staging and how maybe symptomatology ought to play into the staging process is really important. I mean, we clearly see people who are stage 2 but have symptoms consistent with much higher stages. And I don't know about you, but in most cases, my treatment would be based really largely on those symptoms.
Sure. And I mean, and constantly telling some patient, you know, that they have to have more advanced arthritis before you'll intervene, because there's no intervention other than the one that we know always works, these basal joint arthroplasties. That just does not work. Patients can't tolerate that. And so I found that a little bit of arthroscopy and an occasional metacarpal osteotomy for debridement arthroscopy and a metacarpal osteotomy for realignment, I've had a really good run with those surgeries. I think that they work in some patients.
How do you make the choice between an extension osteotomy versus arthroscopy?
I like extension osteotomies in young patients with very little X-ray findings. I like arthroscopy in young patients with very little X-ray findings. I don't like arthroscopy unless there's some other reason for me to be looking elsewhere. I have done arthroscopy most often in the setting of wrist carpal arthroscopy, both radiocarpal and midcarpal arthroscopy. I like that that surgery because I'm already doing arthroscopy. But metacarpal osteotomies, especially in patients who have that sort of strange adduction, which happens early, that's a great osteotomy case because that thumb comes out right as the medial as the proximal portion of the metacarpal moves in. So I like osteotomies for patients who are starting to show deformity, but I like no X-rays for these surgeries, no X-ray findings.
That's a fantastic pearl in terms of the thumb position. I just had one other question, and then open it up to other faculty. What about cortisone injections? You know, how do you figure that in, and how do you feel about cortisone versus hyaluronic acid versus PRP? And I mean, is that something that you consider, or how do you approach it?
I do a lot of it. I don't want to answer for everyone. I will just sort of briefly say what I do. I like cortisone injections. Cortisone injections are a great way to know someone, get to know someone. It's a good first intervention, early intervention. I'm not somebody who injects these over and over and over again. I don't think it's a great sort of permanent management paradigm. Mel Rosenwasser at Columbia has written more about hyaluronic acid injections than anyone that I know. We've had trouble in both places where I've worked getting those approved by insurance. And so that's something I have very little experience with. PRP is something where the patient has to have had a very positive result with it in another joint by another surgeon. And then they come in and they're convinced that that's what they want. Because in both of the areas that I worked, those are not really typically covered by insurance. And so if a patient's asking for it, I'm not against it, especially if the x-rays aren't that great. I have a good salvage in the scenario where x-ray findings exist. So I'm not opposed to it. But the mainstay of non-operative figuring out diagnostic and treatment is a good old steroid injection. I like to keep it under 2 cc's, and I mix it 1-to-1 with some lidocaine. I usually keep them around for a few minutes and find out whether it works, because if a steroid injection doesn't work, sometimes patients don't have the sort of granular memory to know whether it worked initially. And so I keep them around for a few minutes and I say, is it any better? And almost universally they say it's better, but then they'll come back, a lot of them will say, oh, you know what, it did nothing for me. So at least I know the lidocaine worked, we were in the right place, we know the diagnosis, but the steroid isn't enough.
That's great. Virginia, you're just about up, but just finally, John, how many is too many injections?
This is not based on data. I don't want anybody to like extract what I'm about to say. 3 in a place is my limit. That is not always, I don't always obey that. If some patients have cancer, they have other things going on in their life, 1 more injection, doc, until I can retire. But in general, it's 2 or 3. And I don't force people to undergo a series of injections before they can get surgery, especially if they have the findings. I mean, basal joint arthroplasty, and I know that we're going to hear people say it doesn't. I mean, that is just a great surgery. And so, but if it's going to get them to the right time of year, get me past my daughter's wedding, that sort of thing, I like an injection or 2, or even up to 3 for that sort of thing.
That's great. Thank you very much. That was fantastic. Virginia, it's all yours.
Okay, I am ready to share, and we will get this going right here. So you can see my screen.
Yes.
All right. Oops. Don't touch the button. It'll advance your slide. So thank you very much for this opportunity to speak to you about the conservative management of CMC OA, which is one of my passions, and what I really enjoy doing research on and have done, have participated in several research projects. So conservatively, looking at both what the American and European League on Rheumatology advise, they advise non-surgical treatment prior to any surgical treatment consultation. And so they do advise that exercises, joint protection education, and orthoses be given it because it's shown limited evidence for a longer term effect for pain and disability. And recent studies, really, it's very exciting that more recent studies for therapy, which have been, there's been such a paucity of research for what therapy can do and what the effect of orthoses and exercises have shown. We can thank some colleagues in the Netherlands that have been all over this. We have done some here in the United States, but I think those in Europe have really been able to show us a lot, which has been very exciting. And their studies have shown that an orthosis plus exercises demonstrate significant changes in both pain and reduction of disability in all CMC stages. So the greater effect is of course in those in the earlier stages. However, they have included some of the later stages, and those people do show an effect, and that's exactly what we've seen in some retrospective studies we've done at our facility. And these effects are greater than just an orthosis alone. Thanks to Dr. Brand and his therapist Hollister from way back even in 1985, and then a second edition in their book on the clinical mechanics of the hand. They reported that the first dorsal interosseous has a very important role in stabilizing the CMC joint because it reduces radial subluxation in a radial or a distal, excuse me, that should be distal and ulnarward metacarpal pull. And in the study that I've participated in, it's a bench study research that I did with Dr. Julie Adams. We found that the first dorsal interosseous with the opponents provided the strength of stability, with the opponents being the stronger force, but it was the first dorsal interosseous that tempers that subluxation force to maintain or to create some reduction at the CMC on the first metacarpal on the trapezium. And even our recent studies and all the recent studies combined, it's very interesting that there can be a significant effect on patients in an average of 2 to 6 visits over about 6 weeks. So that's pretty exciting. So we call exercises in our world, the therapy world, dynamic stability for the thumb. And what is that? And that it includes manual release of the adductor, as you, Dr. Alfar, spoke about that nasty positioning of the adducted thumb that we really see as being very key to giving patients their thumb back, giving thumb mobility and function back. It includes some mobilization to reduce and realign that CMC. And then muscle reeducation with strengthening to restore palmar abduction, because that's the most osseously stable position. Focusing on the first dorsal interosseous with the opponents firing for that stability. And of course, it's going to use, it includes adaptive tools and joint protection techniques and orthoses as needed. So it's a process, and the book that I'm showing there is a book by Jan Albrecht, who was one of my mentors, who has written a patient education book that many therapists have around the nation. So what about an orthosis? It really does need to be designed or selected according to the needs. So there's a plethora that's available, both prefabricated and custom fabricated. You may need to make one for their activity or their rest, or they may need both. you may need to immobilize or stabilize first, because you're working to reduce their deformity and making something that's comfortable for them, because if it's uncomfortable, it's useless, with a plan to wean from an orthosis, which is really an amazing thing that we've seen in our clinic and many other clinics. The principles of joint protection are sixfold, and for those who aren't therapists, they are just respecting pain, balancing rest and activity, providing exercises, and having them being done in a pain-free range, avoiding positions of deformity, always working to keep it stable, keep the thumb stable, reducing effort and force, and using the larger and stronger joints. And OTs and hand therapists are well known for showing and helping patients understand what are the different equipment available. What is the different equipment available to help them unload their thumbs so they can use their hand in a more ergonomic way. Dr. Hunt had asked me to talk about how to order hand therapy. It might change per state to state because of the different licenses. But as far as I'm concerned, evaluation and treat, eval and treat is really sufficient for me, because I understand the thumb, and we as therapists, we all understand the anatomy. But it's important to communicate any precautions that you may want to share with them. OTs and PTs really have their own practice act and licenses, so we have to operate within that, as well as we're the professionals that know how to treat patients. And we also can promote the intervention of the physician and the approach that you want, and help to reduce medical costs as well. We make evidence-based and best practice clinical decisions, really depending on how the person presents. And if the person's post-op, it's really important for the surgeon to provide surgical procedure and operative notes, because each surgery may be different, and we need to know what those differences are to apply our best practice. So just a little case for that I had recently. This is a woman with right thumb CMC OA. I saw her for a total of 4 visits over 3 months. That was her choice, because she wanted to spread it out. She had a history of a UCL sprain 40 years ago playing volleyball, and she had a recent, gotta stop touching my screen, recent injection months prior to this, for my first visit with her, but she had had prior injections. She'd had previous hand therapy, but only a splint, no exercises. Good thing is she is a retired PT, so she really understood her exercises well and understood her anatomy. She enjoyed gardening and has a home-based card stamping business. When she started with me, she had an activity pain of 8/10. And by the time we finished, it was 4/10 only. And that she said there was really much less frequency, and only with heavy activity. But she said, basically, I'm pretty much pain-free. Her home program included the web space release and lengthening. We started on first dorsal active range of motion, progressing that to strengthening. Talked about joint protection, education, and adaptive techniques, and really worked with her in her stamping business, because it was a lot of axial loading that she did. And then her orthosis that I made, she wore it first wore it, and I like what you said, Dr. Alfar. I had her wear it for the first 2 weeks pretty much full time, and then introducing the exercises, and then she self-weaned out of it to where she was only using it for heavy tasks and that axial loading with her stamping business. So my belief is no 2 thumbs are alike, and that it's not only about an orthosis, but it's about dynamic stability.
Great, thank you.
And stop sharing.
Thank you, Virginia. That was fantastic. Just one question. I find myself often trying to counsel patients on trying to pinch or grip thicker or bigger objects so as to diminish the force transmission across the thumb CMC joint. Is that a proper thing to say, or what do you think?
Um, yes, and trying to pinch something really large. One of the things I counsel people on is learning to use that first dorsal interosseous as they're grasping, which is kind of an interesting point, because when you're having thumb pain, we in our I participated in another study, population-wise, a large population of over 500 people, but very few had the CMC pain, but it correlated highly with weakness at the first dorsal interosseous. So it's really an amazing thing how we can use that first dorsal interosseous to stabilize the thumb. So I will teach people to grasp the object and then roll that first dorsal interosseous, and it's amazing how much stabilization you have at the CMC. So the other thing I teach people is don't use your thumbs, use your fingers as much as you can, save your joints.
We did have one question that asked, how useful is the article and abductor strengthening?
How useful is the article and adductor strengthening? I'm not sure exactly what they mean by article.
They mentioned abductor, abductor strengthening.
Abductor strengthening. How use? I think that we have to use the thumb in its stable position, because it's the first dorsal interosseous and the opponents are only one of 9 or 2 of 9 muscles that control the thumb. So while we want to focus on the first dorsal and the opponents, you also have to, I'm trying to get a thumb in there, you have to make sure that they are also keeping a great palmar abduction and in that C position, so that you have an arch of the thumb, you have the best stability as they're doing it. So you need to fire your abductor, you need to fire your extensors, you need to fire everything. So it's not just a 2 muscle approach, but it's really approaching all of them and strengthening all of them.
Great. Thank you very much.
Mm-hmm.
Dr. Malone, would you like to take over the screen?
You bet. All right. So thanks, Tom, and everyone else for participating and joining us tonight. My task here is to talk about some surgical options when conservative measures have failed. I will, just to add to some of the comments that John made previously, you're going to see x-rays that look terrible, and patients who have those x-rays but are relatively asymptomatic. I think it is important, and one of the things I will always tell my patients is that I will never tell them that they need to have a surgery. They'll tell me when they're ready for it. And I think conservative measures can be very effective for this. And we do see a number of patients who have this condition bad for several years and then tend to fade away or burn out, even though the x-rays look very poor. So, and here's a great example. This picture right here was someone who came into my office yesterday for a totally different reason and has this terrible looking thumb and has no pain and is able to do all of her functions. So surgery choice is certainly influenced by the age and activity level of each patient, the occupation that they need to be able to get back to. What you're going to offer someone who is perhaps retired and low physically demand is maybe very different from what you're going to offer or suggest to a younger, heavier labor with a very arthritic joint. A lot of physical examination things, you can't just get focused on the CMC joint itself. You really have to look at the MP joint. Here, for example, we see this hyperextension instability that commonly develops in later stage arthritic thumbs. And you can't forget chronic ulnar collateral ligament laxity. A patient with an unstable thumb, whether volar plate instability and hyperextension or a chronic ulnar collateral ligament laxity, may not do well if that problem is ignored when you address the CMC joint with a soft tissue procedure. You certainly want to evaluate the wrist and other joints. The wrist, for signs of more advanced arthritis, slack changes, although there is good data in the literature that even in the setting of a slack wrist or even with a proximal row carpectomy, that some of the conventional soft tissue procedures for the thumb can be effective. You want to evaluate the STT joint, because if the patient has advanced arthritic changes in the later stages of CMC arthritis, then they're not necessarily going to be a good candidate for arthrodesis, which we'll talk about here. And then also the MP joint of the thumb. If it's unstable or arthritic, then you need to address that as well. So many options, and you got to pick out which one you think is the best. Again, there's no one right selection here. So options that we're going to discuss include arthrodesis of the CMC joint, and then arthroplasty, which comes in very different flavors and varieties, including trapeziectomy alone, trapeziectomy with some form of suspension, and then we'll talk a little bit about implant arthroplasty. Our goal is to relieve pain and restore function, return the patient to their desired level of activity, occupation, or recreation. But it is also important to realize that despite all of the varied and described varied techniques, no option has been proven superior over the others. And so you have to find what works best for you and your hands. And you got to have a lot of different options available for your patients to fit their demands as well. So talking about CMC arthrodesis, perhaps this is more appropriate for a heavier laborer, someone who has a higher demand for grip and squeeze and pinch power. You think about the anesthetist in your operating room who has to, bag mask airways and those type of things, and the amount of force that type of activity requires it puts a lot of strain across the CMC joint, and perhaps a solid bony procedure may give them a quicker ability to return to that. Other conditions or situations may include paralysis or weakness, severe carpal tunnel syndrome with thenar muscle atrophy and weakness, or median nerve issues, or even radial nerve issues with abductor pollicis longus weakness. Perhaps an arthrodesis is a good option here. We do want to make sure that there's an absence of arthritic changes in the scaphotrapezial trapezoid joint. As in anywhere else in the body, when you take away a motion segment, the adjacent motion segments are going to see more stress and strain and may break down a bit earlier. And so if that patient already has arthritic changes at the STT joint, they may quickly fail their fusion. In this situation, if you're going to consider a fusion, I think you can more or less ignore what's going on at the MP joint. If the MP joint is a little bit unstable and asymptomatic, this likely can be ignored. But non-union is not an uncommon problem after arthrodesis. Published reports up to 20% of non-union, and this is greatly influenced, or the emphasizes the importance of joint preparation for fusion, and then correct implant selection. It is also important to realize that when we fuse the thumb, we change the movement patterns of the thumb. We are bringing the thumb into a position away from the palm, and so they can't get their palm flat on the table, and we'll show that here in these slides. A variety of different technique options, a straight dorsal incision extending distally from the radial styloid out towards the thumb metacarpal, or a Wagner approach, which will give you a little bit better access to the volar surface of the CMC joint. Obviously, it's important to recognize and be aware of the radial sensory nerve branches, because you can do an excellent joint procedure, but you injure one of those nerve branches and you've got an unhappy patient. Preparation here is very challenging for this joint, removing the cartilage and the subchondral bone, so you have cancellous surfaces for fusion. And it has to do with the contour of the articular surfaces, both on the distal portion of the trapezium and the base of the thumb metacarpal. So you really need to have a pretty good exposure here to make sure you're removing those bones, or excuse me, that segment of bone. Don't be afraid maybe to use a burr to get back down to the through the sclerotic subchondral bone. And in some situations, you may need some cancellous bone graft to fill a void that is created. There's lots of options there, locally right through Lister's tubercle or the radial styloid if needed. The position of fusion, as we talked about, is recommended about 35 degrees of radial abduction, about 30 degrees of palmar abduction, and about 15 degrees of pronation. And if you see the diagram here, it's essentially making a fist and putting your thumb over the proximal aspect of the middle phalanx of your index finger and over the PIP joint, and that tends to be a good solid position for fusion. Implant selection is important, and as we mentioned about, there is a high rate of non-union. A lot of this is with older implants, including K-wires, small hand plates, or obliquely inserted lag screws. And many of those are very difficult to provide compression and stability across the CMC joint. And so, you know, as in many other places around the body, if you can't provide compression and stability, you're going to increase your risk of non-union. And here you can see one of my cases from several years ago where our plate broke. Perhaps the use of staples may offer some improved union rates, as these will provide some continuous compression across the CMC joint. Another sort of benefit is if the non-union fails, or excuse me, if the arthrodesis fails and the non-union does occur, or in this situation where a patient had a successful CMC fusion after multiple prior surgical procedures, but then developed STT changes, it can in many situations be converted to an arthroplasty to restore some motion there and resolve pain. Moving on to trapeziectomy, this is included in all part of, as part of all other procedures for the thumb. It can be done in isolation, as demonstrated here. Recommended early authors are recommending temporary K-wire fixation from the thumb to the index finger metacarpal to maintain that trapeziectomy space open. Tight capsular closure important to contain the hematoma that we are expecting to form there, which will hopefully then turn into some fibrous tissue to act as a cushion and interposition material. However, with wires there, this is then recommended to have about 6 weeks of immobilization before K-wire removal. And the results here are very good. And this is oftentimes the correct answer on in-training exams or board questions, because again, this is the cheapest procedure, and no other procedure has been shown to be more effective in treatment of this condition. It has relatively few complications, but K-wires can produce issues with migration, infection, loosening, tendon and or radial sensory nerve injuries. We know that without some sort of suspension, there is a potential for proximal migration of the thumb back towards the towards the scaphoid. And we'll see that if you look critically at all of your x-rays after a CMC procedure, you're going to see some degree of it. Dr. Elfar mentioned that in his talk, and we really don't know if it's a problem. We really have not established the importance of maintaining the trapezial height. But it would make sense that if we can keep our thumb out to length, then we are keeping our motors out to the appropriate length on that length tension curve, and they will they'll work more effectively with greater strength. So I like to try to keep as much length on my metacarpal as I can. Trapeziectomy with implant arthroplasty. Many products have come and gone. They have been made of varying materials and varying designs. You can see on the bottom left the Artelon implant that was popular in the early 2000s and is now off the market. The top left is a silicone implant, and then a variety of other techniques with pyrocarbon or other metal components. They're all very expensive. None replicate the normal joint mechanics of the CMC joint. This is not a ball and socket or a hinge joint, as we are all aware of. Most have been associated with high failure rates, including subsidence of the metallic implant into the trapezium, dislocation of modular components, or extrusion of this orthosphere that was taken off the market several years ago. And so there is a high revision rate with these procedures, and revision can be very challenging in this situation because of inflammatory changes or bone loss that would make it really hard to convert to a fusion, and you'd have to convert to some form of soft tissue arthroplasty based on what remaining tissues are available. In terms of suspension, many different options. Commonly, the Fcr is used as a method to suspend the thumb off of the index finger metacarpal, again, in an effort to maintain that metacarpal height, the trapeziectomy space. Described techniques including the abductor pollicis longus tendon. More newer described techniques, suture suspension plasty, suturing the APL to the FCR to create a sling or a hammock underneath the thumb metacarpal base. And there are some early studies there suggesting that that's a nice technique. And then there are other techniques, including anchors or, as demonstrated here, a suture button option. Again, none here are better than others in any of the literature, and you have to find which one works best for you. Perhaps adding some type of suspension can get this patient out of a cast a bit earlier, allow for earlier mobilization, hygiene, simple activities, and again, perhaps less potential for proximal migration and better long-term outcome, but that has not been borne out in the literature. This is my preferred technique, which is a subtle variation on techniques that have been around for about 50 plus years. I make a longitudinal dorsal incision extending distally from the radial styloid, developing the interval between the abductor pollicis longus volarly and the extensor pollicis brevis dorsally. Here you can see the radial artery in the floor of the anatomic snuff box, which is then mobilized dorsally. And then we make an incision through the capsule and periosteum to expose the thumb metacarpal base, the trapezium, and then the distal scaphoid. A little bit dorsal exposure, you can then develop the interval between the trapezium and the trapezoid. Now, this is an important technique that I picked up actually from one of my former fellows. These are Maglamry elevators. If you've never seen them, they are probably in your hospital somewhere because they are commonly used by your foot and ankle surgeons or podiatrists. And this has made getting the trapezium out so much easier for me. As we all have identified, this is oftentimes one of the more frustrating portions of the procedure, but development of that articulation between the trapezium and the trapezoid and insertion of one of these Maglamry elevators, and there's your trapezium comes out in peace, and your Fcr tendon in the floor of that trapeziectomy space is well maintained and preserved. I then harvest a distally based Fcr tendon graft of about 40% of the diameter, 40 to 50% of the diameter. Here through a transverse incision at the wrist flexion crease, identify the Fcr. I will pass an O-silk suture through that tendon, and then you can see there are more proximal incisions. We pass this silk from incision to incision within the Fcr tendon sheath and use it as a giggly saw to split the tendon all the way up to the myotendinous junction in the proximal forearm, at which point we divide it and you have this nice tendon graft, which is then brought into our trapeziectomy space. I pass it through a hole that I create in the thumb metacarpal base with a 3mm burr. Pass the tendon through there, loop it through itself at the base of that trapezia, or the base of the thumb metacarpal, pull a little traction on the thumb, tension the graft, and then I will suture that knot in place. And then with the redundant tendon material, I will imbricate this, and that is my interposition material. A good closure of the capsule. And then I think what is very important is the position of immobilization immediately after surgery, placing the thumb into abduction. And I will, emphasize to my residents, putting a nice little thumbprint right there in the plaster splint to get the thumb into abduction at the CMC joint, but allowing the MP joint to come into flexion. If you immobilize the MP joint into extension, I think that can lead to stiffness and uncoupling the CMC and the MP joint. Post-operatively, my patients are in a splint only for 2 weeks, and then I put them into a removable orthosis. I let them come out of it for hygiene purposes. Active, unresisted range of motion. They're not holding onto a pen or a pencil. I let them do circumduction with the thumb, tip to tip, all the way to the finger. And as they get over to their pinky finger, I let them try to slide their thumb down their pinky finger. I have them work on both hands at the same time, so they have a little bit of a mirror that they can use. And then at about 6 weeks, I send them for formal therapy. So they'll see therapy, for that first visit to get the splint and get some instructions, but I have them save their visits, their co-pays and everything until we can really get a little bit more aggressive at about 6 weeks. I think it is important to counsel their patients about expectations. All studies, regardless of technique, show a high likelihood of good to excellent results, and that is with improved pain, preserved and improved function, A recent study shows that if you are operating on a patient with this type of procedure who has had symptoms for less than 2 years, there is a greater improvement in quick dash scores. However, as we all know, that there are many patients who go through a phase where it is painful, and if they get through that phase, they may have a joint or a thumb that looks funny but works pretty well. In terms of expectations, it is also important to discuss with these patients how long they're going to be out of work if they are still working. And a study from 2018 out of Sweden demonstrated that there was greater than 120 days of post-operative sick leave following this surgery. And that reason alone is why many of my patients really try to push off surgical intervention for this condition and proceed for a while with splinting, anti-inflammatory medications, and intermittent injections, and have been very happy in doing so. So I'll turn this over to Virginia to add her therapy pearls here following CMC reconstruction. Thank you.
Thank you, Kevin. That was fantastic. And I have some questions
Tom,
regarding.
we can't hear you.
Can you hear me?
I can hear you.
No,
I can hear you fine.
Yeah, you're not muted, but I can't hear you.
Just you, Kevin.
Just you, Kevin. But please, in the interest of time, Virginia, please go ahead.
Okay.
Virginia, you want to take over, and maybe Tom can figure out his audio stuff?
Yes, I'm taking over right
Virginia, now we can't hear you either.
Well, I'm
Kevin,
sharing.
Kevin, can you hear me? I think it may be your computer, Kevin.
Yeah, we can all hear everybody, Kevin.
Slideshow.
Virginia, I'm not sure if your microphone is working.
I'm here.
Unplug and plug
I'm
back
on.
in.
Just a second. Here. Technical difficulties. So hang on. I'm here. You can hear me. I'm on my and here and slideshow. All right. So hopefully you can see this one on post-op hand therapy. Somebody say yes.
Yes, we got
All right,
you.
good. Okay. Thank you, Doctor, for your excellent talk on all the different ways that we will see patients post-operatively, all those surgeries. So I'll talk about the post-op therapy for several kinds of surgeries. Since Dr. Malone started with arthrodesis, post-op care for arthrodesis is really based on the bony healing of the joint or joints, if they're one or two, a CMC or the MP. Typically, they're seen at about 6 weeks post-op for a supportive orthosis, but longer if that's necessary. If it's the MCP, then the care and the focus is to maintain that angle that's obtained at surgery. And if it's the CMC, again, care and focus is to support the angle of abduction that was set at surgery, and not to undo the surgery, obviously. Active range of motion is of none of those involved joints, but specifically thumb IP for tendon gliding to make sure that we don't get any adhesions around the surgical site. As the bone heals, then we're going to move forward towards more wrist and thumb active range of motion and functional restoration. Scar management, of course, is included, in joint protection, of course. We always do that as hand therapists. For arthroplasty, basically there are 3 phases of post-op CMC intervention. The 0 to 4 week is that acute phase, 4 to 8 weeks is the unloaded phase, and 8 to 12 weeks is the functional phase. There was a wonderful systematic review that was done on CMC arthroplasties, and they found that early active recovery is used more often in literature, and that early motion didn't have any worse outcomes or more complications. But the caveat is there's a lack of high quality comparative studies on this population. So the focus really is to prevent previous thumb deformity. Oftentimes people will come who have never had any conservative therapy, and they already have a very tight adductor. with an adduction contracture. They may have motor problems with their hyperextension at the MCP, or maybe even a volar. That volar plate is overstretched and they need to relearn how to use their thumb without hyperextension at the MCP. Hand therapists then are trained to identify and then help to promote re-education toward function in these types of deformities. So our approach to post-op hand therapy, and this is based on literature, protocols, guidelines that are available, but we start therapy depending on really the type of surgery. If it's an arthrodesis, it's usually initiated at about 6 or 8 weeks, as I said. A traditional arthroplasty is initiated at 3 to 4 weeks. The patients are usually splinted for the first 3 to 4 weeks, and then we start some active range of motion. If a fiber wire type, like an internal brace, is done, then we can start that active range of motion of both the wrist and the thumb at 2 weeks. We have 1 or 2 of our surgeons that do the fiber wire type internal brace. Both may start with a forearm-based thumb spica, and in about 1 or 2 weeks move to the hand-based thumb spica. Part of that is because people are a little apprehensive to move. They haven't been using their thumb in a very appropriate way, or their thumb motors are pretty weak after being in a cast for 4 weeks. We stress active range of motion at first in both the wrist and the thumb, but we avoid lateral pinch and opposition all the way to the 4th or 5th fingers. And so I just don't want to see any popping out. I have seen where some of the arthroplasties are undone with too early opposition all the way to the 4th and 5th fingers. So we wait till about 3 months. So exercises help to restore the use of the thumb provided by the surgery, and this can be accomplished without pinching for strength, I think. Restoring the thumb web space helps to improve thumb range of motion and function. And we will focus on opposition, palmar and radial abduction, and using the thumb in a functional, stable way, actually firing all of the 9 muscles that are used to support that muscle. We do suggest to avoid pinch strengthening and focus on the other muscles, extrinsic and intrinsic, to support the thumb, just because I want to not promote any subsidence into that arthroplasty space. So I really hold off on that. I'm sure patients will do their pinching in life, but I just don't promote that in therapy. And as the first dorsal interosseous doesn't cross the CMC, honestly, there haven't been any studies on this, but I think that it's worthwhile to promote using the first dorsal interosseous, because it does work with the opponents to provide that stability. And again, teaching them to use all of their thumb motors to provide that. So as a suggestion for what do we do for unloaded phase and active range of motion, we'll do IP blocking, MP blocking, and then the total thumb active range of motion, inflection and extension, opposition, working on that C position, as well as firing the first dorsal interosseous. And our dose is 3 to 5 times a day, and about 5 to 10 reps, wearing their splints in between their exercises, both day and night. And then the unloaded phase, also for active range of motion, is getting the wrist to move in all planes, still releasing that web space, because I believe that there's still a residual, well, at least I've seen a residual adductor in most cases, and then getting them to stretch out as long as the, depending on the surgery, that they can restore full abduction, both palmarly and radially. as well as circumduction. And then in the functional phase and strengthening, we can begin with isometrics for the wrist and grip strengthening. I teach patients to avoid using the thumb. They're going to use their thumb, but I just don't like to do a lot of pinching, but I'll focus in on first dorsal interosseous strengthening. And I don't have a good picture of that one here, I'm sorry. But abductor strengthening, as well as if they're going to do pinching, and my caveat is to make sure that they maintain good positioning with that. Oh, there's first dorsal interosseous, sorry, I forgot. So that's how I'll use it, either actively or with a rubber band as a light resistance to teach them how to use that. So we will continue joint protection and use of adaptive tools and techniques as they are learning to use their new thumb. There we go. I'll stop sharing.
Perfect. Thank you, Virginia.
There.
I just had one question that I thought might be appropriate for both you and for Dr. Malone. And it really relates to the tendon suspension arthroplasty and the kinds of patients you see that you want to perform that operation on and their functional abilities afterwards. Let's say you have a 63-year-old gentleman who's just retiring as a businessman. He's just an avid single-digit handicap golfer, really wants to play, has a lot of pain, needs surgery, has exhausted non-surgical treatments. And how do you counsel him? I mean, do you say, is it a fusion? Is it a suspension arthroplasty? Kevin, what do you think?
Well, I give them, options for both. And I think, there's good data that even return to heavier labor with a suspension arthroplasty tendon interposition is certainly a feasible thing. Now, one caveat that I have sort of incorporated into my practice is with these, with men, instead of taking half the FCR, I may incorporate the entire FCR, still split it and pass one half through that bone tunnel, and the other half then tie the two limbs together underneath the thumb. It just gives us a much bulkier repair and interposition material. And I also tend to favor that in some, in a woman who has extreme joint hypermobility, just to, again, give a little bit more bulkier soft tissue repair at the CMC joint. But I think the real thing is expectations on how quickly they're going to be able to return to that type of activity. And one of my mentors in fellowship would tell his patients that, there's 3 phases to this recovery. And each one is really between 2 and 3 months long. And the first phase, you're going to hate me. You're going to think that I did something wrong. You're going to have more pain than you started with. You'd never give my business card to any of your friends, and you'd never consider having this done on your other hand. And that scares a lot of patients away from surgery. Phase 2 is you're in rehab. It looks like your thumb, but maybe you think I attached somebody else's thumb to your body because you can't control it the way you want to. You're still not ready to pass out my business card to your friends. And then the stage 3 is, that last, 2 to 3 months where it's the light at the end of the tunnel. You're out of therapy. You're not wearing a splint. Your strength isn't fully there yet, but now you realize why you did it. And you're, writing nice reviews of me on Yelp.
I agree. It takes them about 3 months to go, oh, that was a good thing. Can you do my other thumb now? But for that golfer, I think there are some really wonderful, very soft leather gloves that have been made for golfing that have some really lovely support around the base of the CMC, even if they've had surgery, just to support that that part of the thumb so that they can get back to golfing. I think that it's important, and then just helping them to reduce that adduction contracture. I think that has a lot to do with how tight their thumb is, and then how they impact the club.
Virginia, one of our participants has asked that he has noticed that post-operatively several of his patients, or many of his patients, have weak thumb abduction and extension and attempt to extend the attempts to extend end up resulting in MP joint hyperextension. So how do you approach this with therapy? How do you prevent them from going into MP joint hyperextension and really focus all of their movement and strength on the CMC joint?
Therapists have a really wonderful way to approach that, as far as just teaching a patient and doing what we call muscle re-education, because we want to take those patients and find out where they're using the muscles wrongly, and maybe they're not using their extensors the way they should. And this is a post-operative patient too, so teaching how to find where's the pain-free place and what are the muscles that are supporting that pain-free position, and then focus on that. I think we often forget about the extensor pollicis brevis and the extensor pollicis longus, but how are they using either one of those, or is the abductor pollicis longus gone because it was done in surgery, so we have to find other motors to help support the thumb. So it really depends on what's been done in surgery, and also how they've been used to using their thumb, and how they may have to learn to use different motors to create that pain-free thumb. So it's a wonderful puzzle that we as hand therapists love to help solve. So there's really no one answer, because there's no two thumbs are alike, and we have to figure out what is it that he or she is doing. I often find the EPL is fired and they're not even using the EPB. So that just has to go into find out what the puzzle is, and then figure out how to solve the puzzle.
Thank you, Virginia. Dr. Gaston, you want to bring it home?
Yeah, sure. Happy to. A lot of great points there where I'm pulling up my screen. A few things that I think are just great take homes that got mentioned during all that. One is that we always treat patients, not x-rays. There's a lot of these patients that don't end up needing surgery. And to the end of not needing surgery, I've been blown away. I was not a real big believer in first GI and opponent's pollicis strengthening about 5 years ago. And when I heard about it, and I've really been impressed with how many patients, particularly with early disease, do very well with that. So if you haven't incorporated that into your practice, I really would encourage you to do so. The other final thing that Kevin mentioned in his talk, I hate when I hear people say just isolated trapeziectomy is all you need, because as Kevin mentioned and pointed out in that slide, it's really, those studies are isolated trapeziectomy with 6 weeks of pinning, which is not the same thing as just taking out the trapezium and doing nothing else. So you either need to be doing something with a suspension of either a tendon or a tightrope or something along those lines, or pinning for 6 weeks. So it's not just trapeziectomy. So I'm tasked with bringing it home with what to do when everything we've talked about doesn't work. And, you know, if you just read the literature, you would think that it always works. Because if you look at these studies, 9-year follow-up, 95% are excellent and satisfied, 14-year follow-up, 0 revisions, 15-year follow-up, 100% are doing great, no complications or revisions. And then even up to 18-year follow-up, 54 thumbs, it looks like things are the same as the other side. So it makes us wonder where these revisions coming from. But I think all of us that do these take care of a lot of revisions. I certainly get plenty, not only of other surgeons, but even of my own. So when I was tasked with putting this talk together, it's a little tricky. There's not as much written on revisions. So when I look at my own reasons that things fail for CMC, there's really 5 reasons. Either the MP joint's a problem, the scaphotrapezoid joint's a problem, the CMC joint reconstruction itself has failed, the radial sensory nerve is an issue, or an implant was used that has now failed. So I'm going to kind of take it in the context of these 5 things that we're going to think about and how they fail and what we can do to take care of that. And you really have to approach these with a very non-prescriptive manner and realize it has to be an individualized approach. As Virginia just said, these patients have had many different procedures done initially. So the first thing is what was done. And that helps me know what tendons are now available for me. Was the MP joint addressed? Was the scaphotrapezoid joint addressed? And was an implant used? So that's kind of the building block off of which I kind of make up my treatment for a revision. Are there any nerve-related complaints? And that's an important one because you certainly don't want to get fooled just by that. And then the other thing is, are there other patient factors contributing to failure? Do they have Ehlers-Danlos? Do they have lupus, other collagen disorders that would predispose them to that? And we see the full gamut. I mean, here you see, as one of my fellows called it, the loose rope, the tight rope that was no longer tight. We see an implant that's had an issue, marked subsidence. On the right, my personal favorite, scaphoid removal with an LRTI through the trapezium itself. Not as helpful either. So in terms of the radial sensory nerve, it's important to look at that. You know, what's their sensation on the dorsal of the thumb? Do they have a Tinel sign over the superficial radial nerve? And if those are yes, then conservative management initially with either medications, which can be oral or can be topical. And then I use cortisone injection as well if Lyrica and Neurontin is not managing that. The role for advanced imaging in my personal practice is low for this. I think most of these can be figured out on a basic physical exam. But if you have questions, I think certainly that those are reasonable to do. And then what to do with the radial sensory nerve, if that is the problem. It is a pesky nerve to deal with, and this talk's not really about nerves, but I'll just say when this nerve is an issue, here's the kind of way I approach it. If it's a neuroma in continuity, I will do a neurolysis and vein wrapping if there's not a massive neuroma. Alternatively, a neurolysis and conduit's very reasonable, or excision and grafting if there's a larger neuroma present. If it's an in neuroma, then I typically do excision and grafting. Other options that are described are excision and burying. And then for recurrent failures of this nerve, I have done both RPNIs and TMR for those. The MP joint was mentioned multiple times. I think it's absolutely critical. And as has been previously mentioned, there's 4 things I personally want to know about. Number 1, what's their active flexion and extension arc? And probably most important to me is, do they collapse with pinch? And you hear a lot of talk about hyperextension, and a lot of it's mentioned as passive hyperextension. To me, if someone has passive hyperextension, it doesn't really matter. As long as if they pinch, there's no dynamic collapse of the MP joint, then I don't feel as though I necessarily have to do anything about that. So it's really dynamic collapse with pinch that I'm personally concerned about. And as Kevin mentioned, ulnar collateral instability and or any degenerative change is absolutely critical to know. So again, passive hyperextensions are relevant to me. If they do dynamically collapse, then I consider doing something. And then I break it down, and if it's mild, then I'm going to try to reconstruct it. And for me, my personal go-to has tended to be a volar plate advancement, although there's other things that can be done as well. If it's more severe dynamic collapse, and I think an MP fusion is a very reliable and very good procedure. Other times I will fuse it. If they only have passive flexion of less than 20 degrees, and some people do, they have very squared off metacarpal heads, and even on their contralateral side may only have 20 degrees or less of flexion. To me, if that's an issue and they have dynamic collapse, I'll tend to fuse them. If they have ulnar collateral ligament insufficiency and hyperextension, I tend to fuse them. And if they have degenerative change, I tend to fuse them. One thing I've really liked, patients who aren't sure they want to get a fusion, is something I call a simulated fusion. I'll actually bring them in the office and I'll just numb them up and I'll just pin their MP joint in slight flexion and cut the pin outside the skin. And I give them about a week or 2 just to see what they think. It's a great option because if they love it, you just pull the pin and then go end up doing an MP fusion. If they don't like it at all, you can pull the pin and it's reversible. And then you can proceed with an MP reconstruction or let them just live with it how it is. If I'm going to stabilize the MP joint, as I said, volar plate advancements, what I use the most. I am intrigued. I think the Epb Spiral Tenodesis is appealing. That's a procedure where you cut the Epb proximally, you wrap it palmarly, and then you tenodese it to the volar aspect of the metacarpal. So it serves both as a check rein to passive hyperextension of the MP joint. And if you think about it, it's currently, if they have MP hyperextension, it's serving as a negative force for extension. So you're addressing both the dynamic effect it has and adding it as a tenodesis. I have not used, but other things that are described are sesamoid fusions, EPB to APL transfer, again, taking away a deforming force of the EPB and putting it into the APL. And then temporary pinning in a different way than I described it above. Some people say just put the joint in slight flexion and pin it for 4 to 6 weeks. I don't have any experience with that, and it seems to me that most of those would probably stretch out with time. So here's a case example. This is a 65-year-old I saw in my practice about 8 years ago who came to me with chief complaint of, quote, I can't use my thumb. You see, her VAS was only 2, so it's not that high. And she did have some pain with the CMC grind test, but it really wasn't much. And when I looked at her and watched her function, you can see on that left x-ray, a lot of MP hyperextension. She had marked dynamic collapse. But on the right image, you look at that and think, oh, look how much she subluxated and collapsed. But it really was treating the patient and not x-rays, which I said earlier. I actually saw her and did a temporary pinning in the office, and she loved it. She's like, that's exactly what I needed. Now I can pinch. And so all I did for her was an MP fusion. And believe me, I look at the x-ray on the right, just like you do, and think, how could you look at that and not do a revision Cmc arthroplasty? The answer is because she didn't need it. Her only problem was she couldn't pinch well, and it was really coming from her MP joint. So an isolated MP fusion, leaving this proximally migrated thumb ray, and she's 8 years out now, and I just saw her recently, and she's doing very well, and we've now done her other side as well. So don't forget about the MP joint. Another sneaky snake's the scaphotrapezoid joint. This is going to be a tricky joint to see on x-ray. If I'm not sure, I don't hesitate to get a CT before a revision surgery to see whether or not this joint is involved. If I'm not sure, another option is a cortisone injection to assess its efficacy in the scaphotrapezoid joint. And then operatively speaking, I think it's one of those, if they didn't have it done initially, you absolutely have to check it during surgery. So traction on the index finger will let you see the scaphotrapezoid joint very clearly. If there's any degenerative change and I'm already doing a revision surgery, then I'm going to take the proximal 2 to 3 millimeters of the trapezoid. Now, another pearl is if you try to axially load the index finger, it doesn't go anywhere. So the trapezoid's very stable with axial load. It will not impinge against the scaphoid no matter how little or how much you take. But if you radially deviate the wrist, that's when it's going to impinge on the scaphoid. So after you do a trapezoid resection, maximally radially deviate the wrist and look to see if the trapezoid impinges on the scaphoid. If it does, use a rongeur or whatever else and take a little additional trapezoid. Typically, this is a combined surgery. This is not something I'm typically doing in isolation in a revision setting. What about the CMC joint itself? Subsidence, as was mentioned earlier, it looks bad radiographically, but does not always cause problems. However, if you look at joints that have revision surgery, they virtually all have subsidence. And there's basically, when I see subsidence, I'm going to deal with it. There's two things I personally like. I like a biologic option and a non-biologic stabilizer. I think K-wires are absolutely appropriate and very reasonable. And in some settings, I think they're actually the best option that you have. You can place the thumb exactly where you want, pin it for 6 weeks, and then pull your K-wires. Currently, the in vogue option, of course, is the tightrope, which I think is equally good option, particularly as long as you don't overcompress that 1-2 interval, which can be done. In terms of the biologic augmentation, the FCR, just like Kevin, that's my first choice always. I like it in particular because if you think about where the FCR is in the volar aspect of the index metacarpal, when you pull that tight, it pulls the thumb metacarpal base palmarly. And when that happens, it helps relieve your MP joint hyperextension. So one of the reasons for the MP joint hyperextension is because of the dorsal subluxation of the metacarpal base. When you correct that by pulling the base palmarly, you take off much of the MP hyperextension. In some of the milder cases, it'll actually fully reverse just with a properly done CMC arthroplasty. If the FCR has already been used, I will use the ECRL as kind of my backup. Because it's dorsal, I don't like it as much because, again, you can't push the base of the metacarpal as fall palmar if you're relying on the ECRL to be your suspension. So another thing in addition to subsidence is looking for the osteophytes at the 1-2 intermetacarpal space. You can see here's a case that had persistent pain. They've got a great scapho-metacarpal space, so they haven't subsided really at all, but you see these residual osteophytes in there. So these can be painful with mobility, so you want to make sure you get those at the initial surgery, and that may be a reason that you need a revision. Same principle, if you use a tightrope, be very careful not to over tighten that tightrope and pull the thumb metacarpal up against the index metacarpal, because if it's over tightened, I've seen that be a source of pain. What if you have existing implants? I think this is one of the hardest things to deal with. Kevin showed some pictures as well. Many of these come out pretty easy, and then it's pretty simple. You just remove the implant and do whatever procedure you'd like to do. Some of them, such as this Stabilix, this is a bear to get out. This is an ingrowth stem, and you can see it's occupying about half of the metacarpal. So when you get to these, honestly, you just kind of have to get creative. So this is a case I inherited, and I took them to the OR and said, I've got a couple of things I can try. Here's my osteotome after I was whacking that implant for several minutes trying to get it out. And you can see I made no progress other than damaging my osteotome. So instead, in this particular case, I just had to leave the implant in, remove the trapezium, and I didn't have room to do K-wires around it. But if you look at this implant, it's got holes to suture to. So I just passed a tightrope through the implant, used my FCR as an anchovy, similar to what Kevin described, anchovied that up in there, and was able to do a suspension plasty by removing the trapezium, but having to leave the implant because my fear of trying to get this out with an osteotomy is I'd do more damage than good and not be able to salvage it. And he's now 3 years out from that surgery and doing quite well. What if everything fails? We've done a revision and it still fails. Well, as we know, trying to do the same thing over and over again is not necessarily going to give us the result we want. So the ultimate bailout's a 1-2 CMC fusion. It was described with a large bony block and a lot of different implants that have been portrayed to be used. One thing I'll caution you, the radial artery runs right here. And one of the challenges if you do a 1-2 fusion is the thumb ray is typically subsided. And when you try to bring it out to link, the radial artery scarred in, and it's very challenging and it's in the way. So I would encourage you to do an Allen's test preoperatively and consider the fact that you may need to ligate it to do this surgery effectively. Here's a case of mine. Done well. I'll tell you what, these could do better than you think. So this is a patient that I inherited that had a initial surgery, and I did the revision with a tightrope, and you can see my tightrope has failed. He's got, again, subsidence, a lot of ongoing issues. I did a 1-2 fusion just with staples and bone graft, and here's his outcome. So you can see this patient's got a very functional arc of motion and a very good position of his thumb ray. He can't get it all the way flat, but he's pain-free and very satisfied. So in summary, the 5 things to remember: assess the MP joint for dynamic collapse. If it's mild, consider stabilizing that with either a volar plate advancement or an Epb Spiral Tenodesis. If it's more significant, or if they have associated MP instability from ulnar collateral ligament or arthritis, I would fuse it. Check the scaphotrapezoid joint. If it's an issue, take away 2 to 3 millimeters. The CMC joint, when you revise it, I would consider a biologic and a non-biologic stabilization concurrently. Make sure you've assessed a radial sensory nerve, and if there's an implant that's been placed that's failed, you really kind of need a creative combination of all of the above. Thank you.
That was great, Glenn. Thank you very much. One question that came through the question and answer line would be directed toward you, and also probably to Kevin. And it really relates to something both of you mentioned just briefly, and that is the patient with both thumb CMC arthritis that requires surgical treatment and a slack wrist or arthritic degeneration between the scaphoid and the radius, for somebody who would probably be a candidate for either a proximal row carpectomy or for a scaphoid excision for corner fusion. How do you time those two things? How do you deal with that combination?
Yeah, great question. I'll tell you my experience. First of all, one of the most important things to know is it's absolutely fine to do both. I've had several patients who I've done either a PRC and a CMC arthroplasty or a scaphoid excision mid-carpal fusion with a concomitant CMC arthroplasty, and I really haven't had any issues. I actually have done several of those simultaneously, and I really haven't had too big of a problem. I think a lot depends on your tourniquet time and certain procedures, particularly a PRC and a CMC arthroplasty is not too bad to get done in one tourniquet time, and I really haven't had much trouble. So I don't hesitate to do them simultaneously. I do it the exact same way I always do for my CMC.
What do you think, Kevin?
I have not had the situation where I've had to do them simultaneously, but I don't think I would be hesitant to take someone who has had a PRC and do a CMC arthroplasty or vice versa. And that's pretty well borne out in the literature as well.
So either order is fine, no difference to you. Okay, great. Well, I think Virginia, in interest of time, I think we probably probably ought to cut it off unless you have, do you have any specific things you'd like to mention in regard to revision surgery?
No, I don't know if I can see if you guys can see me. I had to change computers because my computer all of a sudden went down and it's still on black. So I'm on my husband's computer. And so, first of all, I want to say, can you hear me?
Yes.
Yeah, I was going to
Okay.
say that's okay, Virginia, because we're
So-
out of time in regard to that anyway.
Yeah, that's okay. I just wanted to say thank you to Dr. Gaston for mentioning the first dorsal interosseous and the opponents and how important it is in therapy and in post-operatively. And yes, managing any kind of revision is all about the anatomy and what's there and how we can help the person get back to function. And that's all.
Well, that's fantastic. I really appreciate the efforts of all four of you. I think those were incredibly informative and well thought out talks, and I hope the audience enjoyed them. And a special thank you to those of you who have tuned in for this. We are so appreciative of your attention and your time on an evening such as this. And I wanted to make sure you knew that there were some other interesting webinars coming up through AO Trauma North America. You can see in March, complex elbow, June, tendon transfers, August, soft tissue flaps for the hand, and finally, December of this year, hand infections. And also just a final reminder that there will be a poll at the end of this talk, and there you see it. And that will help you with your CME. And so please perform your evaluation. And again, thank you very much to all involved.